going to introduce Diego Zanolli from Chile, represent.
Hi, Selene.
She's going to
How are
talk.
you doing?
How are you?
We're doing great. We have a beautiful
Good.
day here in Santiago, here in South, and we are strong, just as you are,
Excellent.
guys.
Well, I
So
appreciate you guys all coming on, and it's all yours. Tell us how to avoid the booby trap.
exactly. So ankle fractures are usually they're called the residence fracture. You just leave the resident, the first year resident, the second year resident to take care of it, and sometimes it's actually not a good idea to do it, but. And because of that, it's always wise not to look down your contender. And we'd like to, highlight some concepts that are gonna help you out, and we hope you don't forget the next time you dance with this kind of problems. But first of all, I'd like to introduce all my crew, my team here for this hour. First, I would like to introduce Andres. Andres, he did a fellowship in trauma in Dresden, Germany, and he is currently the chief of the Foot and Ankle Surgery Department and Clinic Alemana in Santiago, Chile. And he was a past president of the Chilean Society of Foot and Ankle Surgery. My next.
Hi, Diego.
Hi, Andres. How are you?
Perfectly.
Perfect. And our next team companion is Mario Escudero. Mario, he did a fellowship at the British Columbia at Canada, and he also trained at Barcelona, University of Barcelona, and he currently works with us in Clinic Alemana with me and Andres, and he also practiced in Jose Joaquin Aguirre in Santiago as well. Hi, Mario, how are you?
Hi, Diego. Thanks for the invitation.
Well, I'm glad you're here. And last but not least, Pablo. Pablo, he's a foot and ankle surgeon. He also trained in Europe, and he's the current vice president of the Chilean Foot and Ankle Society. Pablo, how are you?
All good, Diego.
Can you hear me? Perfect.
Perfect.
So, and myself, I did my training at Duke with Dr. Parekh and the other members of the team, and also I work at the military hospital in Santiago, and I'm the past president of the Chilean Society of Foot and Ankle Surgery. And without further ado, I'm gonna show you the fight plan for this hour. First of all, Pablo will talk about posterior malleolar fractures, and then Andres will talk about treating patients, elderly patients, and fracture in this population. And last, Mario will talk about diabetic neuropathic ankle fractures. And if we have enough time, I think we will. We have some cases to discuss and see how we skip the booby trap. So, Pablo, you're up.
Perfect. Can you hear me good?
Yep.
Perfect. So thanks, Selene, for the invitation. It's a pleasure to be here another year. So my case, there's no trap in this. So this is a 67-year-old female. She fell from the stairs at home. She's a healthy female. She had good soft tissues. There's no trap in here, as I said before. So Mario, this is 2 a.m. in the morning. You're on call, and the ER doctor texts you with these X-rays. What are your orders to him? You're at home. He's in the ER.
Okay, so probably I would take, I'll tell him to try to do a pelvis reduction with a cast, even though, yeah, I would tell him to do that.
Yeah, probably that's what we all do. That's what I told him. So he's a very good guy. And he texted me like hour and a half later. So Pablo, I did two good attempts. I can make it better. It's a little bit different, but I'm sure it's not good. So Diego, now you have this tremal fracture. You can get it. You can get a good close reduction. What do you tell to the ER doctor?
I have to tell the ER doctor to keep him on zero regimen, so I can have to take him to the OR, because we have to make sure. I mean, something's happening, because if the guy is skillful and he knows how to get things reduced, and he doesn't reduce because probably there's some interposition of some tissue or whatever that is blocking the reduction. And forget a good idea, probably we could take better images to figure out what's going on. Probably ask for a CT scan, or yeah, that what I would do. But definitely, I mean, I need to if I cannot get the reduction closed, I need to open it. That would
Okay,
be
so pulses are great. Soft tissues are in good conditions now. So you would like your CT scan before you go to the OR, or probably you go to the OR, get an external fixation, or you try to get another close reduction and then get your CT.
I mean, a CT scan is only a 5 minute, process. It's not like an MRI or something like that. So probably, I mean, if we're waiting for complete the fastening for the surgery, it may be a good idea to get. I mean, it wouldn't hurt to have a CT scan. It's not the best option. Obviously, everyone knows that you should get the CT scan after you get the reduction, or after you put a external fixator or whatever. But in this case, I think it's not that bad to have more information before you step into the OR.
But
Perfect.
can I
How about
start?
you, Andres? Yeah, you have more experience than us. You think you can
Why do you say
get it?
that?
Because it's true. So
No,
do you think you can
okay.
get a good close reduction on this one, or
No,
you're
no,
okay
no.
with
If with two attempts, if you have a good doctor and it's not possible to make a good reduction, it's necessary to make a surgery as soon as possible. But first, I would like to have a CT to understand better why it's not possible to make a good to do the reduction.
Okay, so it seems that
Okay, and I have a suspicion, but it's just a suspicion. I
okay.
prefer to see the CT.
Okay, so
Please, Pablo,
everyone
enlighten us.
is
Show us that CT. Show that image.
so I did what everybody is thinking. I did my CT before going to the OR, and well, it showed a complete ankle dislocation, and it shows that the fibula is trapped in the posterior part of the tibia. So I know that you all guys know this, but this is a Bosworth variant ankle fracture. These ones are very, very tough to get reduced, to get a close reduction. So that's why. So this is a common variant. I think you can see it a few times a year. If you work in the ER, you should suspect it if you have a hard time getting the right close. So yeah, this is what we are dealing now. So what now, Mario? Do you think that you're in the OR now? You have your CT. This is probably a type 3 posterior mal. You have two fragments, a posterior medial and a posterior lateral, a very standard fibular fracture, and a small medial mal fracture. So you think you like to do an external fixation on this one? You want to open it? You have any concerns about all the manipulation that these soft tissues, the ER, with all these reduction attempts?
If the soft tissues are okay, I would do an open reduction and internal fixation. As you said, this kind of fracture need to be reduced at the OR. It won't be possible to do in a close reduction. It's very difficult. And I would probably do a posterior medial approach to reduce the posterior fragment, then a lateral approach in the prone position for the fibula, and I'll turn the patient to do the medial mal. That's probably what I would do. In terms of hardware, I would use, how old is the patient, sorry?
67. Healthy.
57? Okay. The
It's
bones
not
okay,
so
probably
young.
I would use
Very young.
plate, two plates, yeah.
So when you're talking posterior medial, you're talking about the supine posterior medial approach between the tibia and the tendons,
No,
or the one that is next to the Achilles tendon, the straight approach?
the one that is next to the Achilles tendon in prone position. I would do the posterior part of the tibia and the fibula in prone position.
And then you flip the patient for the medial mal. Okay.
Yeah, in my hands, yes.
Uh,
Some people do it like
okay.
in prone
Yeah.
position, the medial mal. I
And
feel it.
before talking about hardware, where do you start first? Posterior with the
Yeah,
posterior
I would
mal,
start first.
or yeah?
Yep.
How about your hardware? You like locking plates for this one? Only
As I say,
screws?
she's 67, right? For the posterior part, I would not use a locking plate. Probably for the fibula, I would use it. But I think you can do this case with regular third tubular plates as well.
What do you
I
think, Andres? Do you
I don't
agree
like in
with
this.
Mario?
I don't like in this case the use of very big plates. I think it's necessary to make a good reduction and add screws or regular plates, not blocked plates. It's not necessary in my hands. And also in this case this is not an osteoporotic fracture, and I think with a normal plate you can fix it as well.
Diego,
I
anything else
agree.
you
I
want
agree
you want
with
to add?
Andres. Yeah, I agree with Andres. I honestly, I obviously I start posterior. I agree with the posterior medial approach. It give me a beautiful, I mean, the whole picture of what's going on in there. I put non-locking plates in the rear part. I like to put a screw through the plate, not only as an anti-gliding setting, but also try to catch that distal fragment as well. And after I do that, I agree with Mario also. I think that since the fracture of the fibula is too low, I think a locking plate in a 67-year-old patient will be appropriate. Will be appropriate.
Okay.
Do everything supine, of course. I wouldn't turn down the patient. I do everything in a supine position.
So you will do this whole
In
case
every
in
case,
supine position?
I don't know in every case,
Oh, no, this one.
lastly, no, this one
in
I
this
probably do
case,
everything. I'll do everything supine. Yeah, I'll do it. I
So
wouldn't
so
turn
you would
down.
I
like
do
for
everything in prone.
Sorry, in
so
proposition.
oh
I was mistaken. Sorry. Yeah, in proposition.
yeah.
Okay, prone position.
Yeah, sorry, my mistake.
Yeah,
The
so
other side.
I don't have to agree with myself.
uh, so this is a drawing that I try to make for what I can see with my posterior lateral and my posterior medial approach. I think that with my posterior medial approach, I can see most of the posterior part of the tibia with a not so big incision. With my posterior lateral approach, I need a bigger incision, and I'm some kind of limited exposure of the most medial part of the posterior mal. So for most of these cases, I rather go posterior medial than posterior lateral. I know that I need another incision to fix my fibula, but I really don't care as long as the soft tissues are okay. So I rather to take a good look at it and make another incision for the fibula. So that's what it
Paulo,
looks like.
Paulo.
Yeah.
And in the post-op setting, do you see any difference while using a posterior medial or a posterior lateral? And do you have any differences in the post-op regarding, I mean, rehab or range of motion or stiffness of the joint? Have you seen anything
Yeah,
like that?
we can talk about it later, but my post-op protocol had nothing to do regarding my decision to go posterior medial or posterior lateral. Um, I think, and I don't know if there's any evidence about this, but in my experience, I have a little more stiffness in my posterior lateral ankles than in posterior medial, but probably that's because I need a bigger incision and I have to move some tissues around to go for the fibula also. I got more scarring, but it's just my feeling. And I like better medial. I can see the whole thing. I can manipulate the fragment a little more easier. You can get this medial fragment that sometimes is very small, but you want to get it fixed. So, I like it better. But that's just me,
Gotcha.
So yeah, that's what I'm talking about. You can lift these fragments. You can get it clean. You can sometimes even get inside the joint and take out these small pieces that get like impacted in these fractures. Sometimes they act as loose bodies inside the joint, or they are prominent. So most of the time I take them out. Sometimes if they're big enough, I can fix them with a K-wire. But that's what it looks like. You are very comfortable to reduce this fracture. I always start with the medial part of the posterior mal, and then I put the posterolateral fragment that most of the time goes a little bit over, like a door. It closes over the posterior medial fragment, and this is what it looks like. So I did the whole case prone. I like to use tubular plates, regular plates for these cases. I don't think that I have used locking plates that much for posterior mal fractures. Very elderly patients, I think they're or diabetic. Probably I would like to get a more stiff hardware, but for most of the cases I do not. I like independent plates if there are small fragments. I don't like uses of only screws. If you have small fragments, there too much stress in the head of the screw, and most of the time I ended up like tearing this fragment apart. So I like this evenly compression that the plate can give me. Lateral approach for the lateral mal and a posterior plate. Sometimes this interfragmentary screw can be a little bit tough to get, but you get it with a little bit of practice. And yeah, the most tricky part absolutely is the medial mal. I hate it, but I hate it even more to flip my patient. So I try to get it in the prone position. But yeah. So what is your
Pablo,
yeah?
I have a question for you. Is there any space to put just a screw on the post fragment and the posterior fragment, or no? Or are you using in every case plates?
Yeah, I was talking a little bit about it. I think for small fragments, elderly patients, very thin fragments, very distal fragments, I like to use plates. I think that you have more even compression. You have less risk to break the posterior fragment. But if you are in a type 4 Ramel, I think only screws is great. Sometimes screws for get the compression at the joint, and a small anti-glide plate at the apex of the fracture. But yeah, I think you can use only screws in some cases, but in these kind of cases, elderly patients, very thin fragments, very distal, I like to use plates. So
Pablo,
Mario,
there's a couple of questions.
sorry.
A couple of questions
Yeah.
in the chat. I mean, actually, there are some comments. Maybe you can help us out. Sharmila Thompson says that if for the case, she will put an external fixator first to get it reduced and then get the scan. Do you have any thoughts on that,
Yeah,
or like we said before? I mean, there's no problem in getting the CT scan earlier.
I think you can go both ways if you are confident, and if you think that you totally understand the CT with that dislocated ankle. You can go to and you have good soft tissues. I think why not fix it right away? But if you have a smoker or a very diabetic patient, you have poor soft tissues. I don't know. Probably the good thing to do is get an external fixator, then get another CT, rest the soft tissues a little bit, and then go in again. But
Yeah.
for me, in this case, healthy patients, probably the time lapse between the fracture and the fixation was like 10 hours or so. So for me, it wasn't like I needed to do an external fixation, but I understand that someone will feel more comfortable doing so. So yeah, I think it's okay if you want to, but I think it's okay also to get it a primary or IF.
Okay, and the next question I'll ask, I'll like Mario to respond it.
Can I say something about?
Sure, sure.
Yeah.
Diego, can I say something? But this is a buttock variant fracture, right? So the fibula get locked behind the tibia. So with the external fixator, it will be very hard for me to reduce it as a close reduction. I don't know. In my experience, I don't have many, but I always open it for that reason. So do you have any tips that you can share with us if you want to do it like with an external fixator to reduce that fibula?
Yeah, so probably
That's
if you
why
want
I
to do
wouldn't
that,
do an external
yeah,
fixator.
yeah, that's a good point, Mario. I am totally agree. So probably if you want to do an external fixation, I think that you need to at least get the fibula reduced. So probably just do the fibula and then get your CT scan, like what we were taught to do like several years ago with pilon fractures, but we don't do it anymore. So I don't know why, if we stop doing that in pilon fractures, we're doing that in cases like this. So that's why for me is a primary ORAF.
Okay, and then Mario, since you
Thanks.
you brought this up, there's a question from Christian. Actually, it's a comment. He says he do everything on a lateral position. What do you think? Lateral, prone, supine? Help me out.
Well, you can do it. I mean, it's as you feel more comfortable, I think it's fine. If you do lateral, probably you will. I don't know what kind of approach is he doing with lateral, probably a posterolateral, and I think you can reduce this fracture in a posterolateral approach, and then you can do your fibula and then your posterior mal fracture. I know some guys that in the lateral position, they kind of change the patient a little bit, so it kind of get in a supine position to do the medial mal. So yeah, I think it's doable. I think it's what you feel more comfortable to do.
I think
The
Christian
only
is
thing
talking
I know
about
is
sorry, I think Christian is talking about the posterior approach, the posterior medial approach that goes between the tibia and the tendons. So you can like slip in that interval a plate and do the posterior mal.
I mean, it could. I think it's easier if you may do the whole thing prone, and then probably if you want to go supine, then you just take the bean bag or wherever you have and make the patient fall over, and then do it if you feel more comfortable anteriorly. You could do that, I guess.
Yeah, I think it's also a good approach. You can do the whole case in supine position, but for me, it's a little bit harder when I want to use plates and I want to reach the very lateral part of the posterior mal, going with that approach. So that's what I like. That's why I like to go with a direct posterior approach.
Okay,
For me, it's easy to do that.
For me,
easier to do that
I understand
from
that for some
posterior.
people. Yeah.
Okay,
but,
let's move forward. I guess we
I have one last question, Diego. A quick question for all of you guys. So, what is your rehab protocol on these patients? Very quick. When you start weight bearing, Mario?
1 month.
I start right away with your fixation. I will start right away. Partial weight bearing, 2 crutches. I don't. I try to weight bear as soon as possible. And I think you can do it with this patient.
Okay, Diego, you start
Maybe.
1 month.
No, yeah, I'm not as bold as Mario is. I wait 1 month, and also you have to make sure. I mean, usually, I mean, continue use the cam boot because I want to protect those approaches. I mean, if you start moving right away to avoid stiffness, you may have some issues regarding your wound and have wound problems, wound DSNs, even infections. So I start moving them out as soon as I take the stitches out. I would say 3 weeks from the surgery, between 2 and 3 weeks, mostly 3. And I start moving at that moment and weight bearing partially and as tolerated, even 100% from the week 4 and so on.
Andres, just give me a number. We are a little bit late.
Four
When you start
weeks.
weight bearing? 3 weeks. Yeah.
4 weeks.
So for me, 4 weeks for Andres. So I start moving them 1 week, and when I remove the stitches at 2 or 3 weeks, I start weight bearing these ones. So that was my case, Diego. Just be aware of ankle fracture variants. You have to know them to treat them.
Yeah, I agree. And like you said before, if you're not prepared, you're not going to get them reduced. And it's always important to have a really good idea and understanding of what's going on. Andres, please take control, and the call is yours.
Okay, thanks, Diego. I tried this case to discuss because I think we have a lot of discuss. Uh,
Did you
oh,
take control already?
yes. Can you see it?
Yep.
Yeah. Yeah. A female, 92 years old with dementia. She can walk at home using a walker and with an assistant. And so it's a very limited function. She tripped and fell down, twisting her right ankle, and came to the ER, with those X-rays. As you can see here, it's a very, very osteoporotic fracture. It's a bimalleolar fracture. I don't have better image, but it's a bimalleolar fracture. And here the doctor did a reduction and used a plaster cast. Okay. It seems okay, the reduction, or not for you? Enough for 22 years? Pablo? It's good enough for 92?
No, it's not. The reduction. Sorry.
The reduction, the left,
Yeah,
on the left side, on the left side.
yeah. I have a
Don't
really
be,
On
small.
the right, pardon, on the right side.
don't be so hard on the ER guys. They try to do a
Yeah,
good job.
No,
you
that,
know,
he did it a well work.
it's standing in equinus position, but I think the joint is reduced. The medial mal seems. I have a really small image here, so the medial mal seems like real distant from the tibia, but
Okay.
92 years old,
Appropriate.
probably good enough for now.
And also, she had, before the injury, she had a little equinus. Okay? That's is part of the treatment. Okay. And she came back to my office 10 days later, and she decided to remove the cast because it's not necessary. And she came to my office with those X-rays. So what we can see here is that it's a real subluxation of the tibiotalar component, and the soft tissue are okay. So now what? What can we do in this case in your office 10 days later with those X-rays? Are you going to make more studies, or maybe you try to do a new reduction, or maybe consider a surgery? And what type of surgery? Mario, what do you think about this case? What are you going to do in this case?
I would order a CT scan just to know better the fracture. But I think she's the perfect candidate for a TTC nail. I think she has dementia. She probably will weight bear anyway, whatever you do. So you need a stronger fixation. Usually when I do this, I try to prepare the joints, minimally invasive with the scopes or with this burst. But in this case, probably you could use just the nail because because of the characteristics of the patient. So I probably would do CT scan, and then a TTC nail.
And Pablo,
And probably
in
with
your hands.
infiltration.
Yeah, I'm agree with Mario. If she's a non-compliant patient, I will be very concerned in any of using a cast again. I'll be very concerned if in doing a regular internal fixation. I can imagine what you're thinking, Andres, and what what did you do in this case. But I would like to do an internal fixation that can allow me to wait very immediately. I can go minimally invasive to prepare the joint, as Mario said, and yeah, probably TTC in this one.
Okay, and Diego, what do you think about what do you think about the open reaction and internal fixation? Is an option in this case, or for you not, of course?
Always an option, but the thing is, she's 92. She probably, we don't know. Like, I mean, how the vascular status of this lady is, or if it have any issues of that. And like Mario said, I mean, she probably she wouldn't is also non-compliant, but also, I mean, her condition. I mean, while walking or activities will be very limited. So, I mean, probably a less invasive approach will be more appropriate. And I would like to comment that we have a case like this one in the hospital a couple of months ago. The lady need to get an external fixator installed, but the lady had very poor toleration of that external fixator and had a very severe wound problems. So I think, like Mario and Pablo said, the TTC is the way to go.
Yeah, I didn't do this, of course, and just to remember that in those specific group in this specific group and very old patient, it's necessary to consider the suboptimal bone density, the poor blood supply, and the soft tissue fragility, and also the frailty of the patient and the pre-injury level of activity. Those things are very important to consider. And in the picture on the left side, on the right side, you can see problems with when you do an internal fixation in most of the cases. So of course I don't think about this option. The TTC was an option, but the family, they didn't agree with this option because due to the anesthesia. So we need to do some things to protect the patients, but with less anesthesia, just a sedation and local anesthesia. Due to this condition, I decide to do this. I just make a new reduction using two key wires to put in the fibula and tibia. I use a key wire to make a reduction on the medial side and add a styrman to protect the tibio-talar joint. Of course, that is not common. That is.
Andres, sorry, you have to.
I don't think we're seeing your
next slide. You're in the same slide as before.
Yeah, I know.
You need to advance the slides.
Push to audience. A ver, baby.
There you go.
Yeah, there you go.
Yeah. Okay. It's okay.
Perfect.
Yeah.
Okay. That's what I did in the OR. It takes less than 20 minutes to do that with less sedation, and that is good enough for this patient. 6 weeks later, you can see here the styrman, and the both bones are healing so well, not more or less, it's okay. And I removed the styrman, but you can see the equinus. That is a real problem. That is a big problem to deal in this patient. And
Andres, remember to click the next slides.
I did it.
Yeah.
6 weeks again. 6 weeks later, I removed the Steinman, and you can see here both bones are healing in more or less a good position, and the tibiotalar joint is more or less congruent. But she developed more equinus. That was a big problem, and it was necessary to add physiotherapy, intensive physiotherapy for 2 months. And later, she started working with the walker, with assistant, but I think in this case was good enough for her. Any comment or critics?
I mean,
think
it's
you
easy
get
to criticize
a
when you are
reduced.
not the surgeon.
Yeah, I think your results are good. You get a reduced ankle, but I will be very concerned of the post-op period with this lady. If she tear up her cast before, I will be very concerned about these pins in the weeks after the surgery. But it seems to do okay, and it been holding up great. So I think it's a
Mario?
good
Yeah,
job for her.
Mario, can I ask you something? Because you were the first to put up the TTC nail up in the table. With this lady with that kind of osteoporosis, would you have any concerns, for example, regarding the length of the nail or any other things we should care? Because it's easy to say, you know what, this is the perfect case of a TTC. But I mean, it's a soda cracker. I mean, it will break just by looking at it.
I know I try to use the longer nail that I can, but yes, I don't know how long I have to use it. I think you're asking about the stress fracture in the tibia, right?
Exactly. That's exactly what I'm thinking about.
Yeah, it's something that I don't know the answer. I try to do it like as long as I can to go to the metaphysist, but yeah, it's a concern. But I think it's the small complication, I would say, with this kind of patient that are very tough, right? Because I'm not worried about the fracture in this lady. I'm worried about he's getting immobilized, and then they behave like a hip fracture, right? So they have a lot of the immobility syndrome problems after this. So, but I agree with you. It's a big issue.
Good. Any other comments on that, Pablo or Andres? Or you may have
no.
any last remarks, Andres, in your last slide?
Yeah, it is important to remember that ankle fracture in this specific group are a challenge for the ankle surgeons. The open reaction and internal fixation is not a good option in most of these cases, and it's necessary to consider the use of minimal invasive techniques to be a good alternative to avoid the risk of complications, of good complications. And it's a challenge, but it's a challenge that we need to be prepared because the population will increase, it will be old every year. So I think it's important to be good with this. Yeah.
Absolutely, absolutely. Well, Mario, please take control of this and let's move forward.
Okay, so I'll present a case on a patient that nobody wants to operate on it, but
Oh, boy.
unfortunately, we are getting, yeah, they're getting very common, right? So, uh, I don't know if it's passing the slides. Can you see the?
No,
No.
you
The
have to
slide
take
or no?
control first.
Do you take control
There
already?
you go.
I did,
There
and
you go.
then okay, I got it. Okay, so he's a 60-year-old male, diabetes, hypertension, construction worker, non-smoker, BMI 35, and HbA1c is 11. So big issue. And he has also a diabetic neuropathy in his physical examination that I could take from the charts, because the first surgery, I didn't do the first surgery. I received this patient from another center. So that's the information I have before. But here are the x-rays when he arrived to the ER department. Here are some videos that.
Can you move the slide forward? Or and there you go.
Yeah, it has. So here's the fracture. And then this is the CT scan after the fracture got reduced. You're able to see it.
Yeah.
Sorry, Mario,
Okay.
can I ask, I mean, if you have a nice reduction, and this is a patient with a H1C of 11, I mean, this is a guy no one actually wants to have, like you said, as a patient. I mean, can you leave it there? I mean, and just heal in that condition? Would you consider that?
No, I won't. He's active worker, 60-year-old. I mean, he's diabetic, but I wouldn't be that mean. I would try to do a good fixation, try to avoid big approaches, but I would fix it.
Anyone on the panel? Andres, Pablo?
I will fix it also.
No, it's necessary to make the surgery. Yeah.
I agree, and that's important. I mean, people don't have to be fooled. You have a good reduction, a very bad patient, but you need to fix it anyway.
So Pablo, what would you do with this case? What would be your approaches? Or
Yeah, so I was thinking between the last case and this one, and I think the thing is where to draw the line, and when we decide to do a TTC in these high risk patients, and when we decide to do an open reduction and internal fixation. So I think that part is very hard. For me, it depends in diabetic control, soft tissues, the vascular, pulses and all that stuff. But if I have good soft tissues, a good diabetic control, that it seems not to be the case, I try to do an ORIF, and in these cases, bad diabetic patients, I think TTC is the option. I think it's very, very risky to do internal fixation in these patients. We have some disasters in our hospital when we try to do these cases open. So most of the time we try to go with minimal invasive fixations. So TTC for me.
okay, we will. So this is what they did.
Oh, boy.
Sorry, here it is. No, it's here. Okay. So this is what they did. I reviewed the charts, and they use a posterior-medial approach and a posterolateral approach, and anterior approach to get it reduced. Andres, what do you think about the reduction? It is okay? Would you do something else?
The reduction for me is okay, but it's a very, very minimal invasive surgery. You did a good job if it's in a normal patient, but not in a diabetic patient. I think it's necessary to add more hardware. Yeah, you are at risk to develop complications, not wound complications. So I think that is not enough stabilized, and that would be a problem in 1 month more. I think it's not good enough the result, and it's necessary to add more hardware. Maybe the syndesmosis is still open. Maybe.
What-
So Andres,
I'm not sure.
how do you add more hardware to
Exactly.
this case?
That's exactly what I want to ask.
How
You said-
would
You can put
augment
for-
this fixation?
Yeah, it's necessary to augment. Maybe using 2 or 3 syndesmal screw, 3 cortical or quad, that it doesn't matter, but you can add a plate in the fibula using a minimal invasive approach, So, or if it's necessary, or you can put an external fixator for 1 month. Yeah, but I think it's necessary to put enough hardware to protect the construction. Yeah, and that is very, very, very small fixation.
And another
Okay,
question on
for
this.
Diego, question for you, Diego.
Okay.
Weight bear, when you start weight bearing these kind of patients?
Well, I'm glad that you asked, but it's usually when we ask later how much weight bearing we use for normal patients, I said 1 month. Usually for diabetic patients with neuropathic fractures, usually this time doubles. You have to think about 2, even 3 months sometimes, and more double the hour, double the non-weight bearing period, and that will be the way to go with this patient. We have to be very, 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 very cautious. Even if you do a TTC, I'll give him enough time. Maybe try to have any evidence of bone healing. Maybe a CT scan prior to start weight bearing. That will be the way to go.
Okay. So because of the time, we'll move forward a little bit. So 4 months later, he arrived to the office with me, and here are the X-rays. Any comments, Pablo?
It collapsed. It seems like a Charcot arthropathy in a heavy diabetic patient. So that's where we are all afraid of with this kind of osteosynthesis. So now you have a big problem.
Yeah.
And here the CT scan.
It seems that you got some
Again, the
callus
CT
on it.
scan.
It doesn't seem like an starting process. It seems more like a coalescent phase of a Charcot.
Yeah, it still has some
It
redness
seems
in the. So in the physical examination of this is the images. Here is the physical examination. It has some redness, not very much. I think it was in going to coalition's stage of his Charcot. A little bit of swelling, no fistula, good pulses, and food sensation was diminished. So Andres, what would you do now?
in my hand, I use a CCC, a cast, yeah, to immobilize at least 1 month or 2 months, and then decide the final surgery. Yeah, I think she will need a TTC at the end, but first this swelling, the redness, I think is not in a good. It's not good to make the surgery right now. I don't think is that an infection that is very common in diabetic patients who develop this type of complication as an Charcot, but this patient needs rest and it takes time, and then make the final surgery.
Great. I agree with you. And Diego, what do you do to rule out infection in this kind of patients, or do you just rely on your physical examination?
No, I agree. I mean, there's always the ghost of, hanging around. Is this infected or not? The only way to do that, you can take the blood test to see if the PCR, the proteins is C, it's up or had a white blood count elevated or whatever. But at the end, what is going to respond is have some cultures, and probably I'll go more clinically. And if my exams are good and I can see the redness goes out after keeping the feet elevated for a while, and probably I think it's more like a Charcot instead of infection. But at the end, you'll need a culture if you want the final answer for that.
Okay. So
You did something
blood work was
different.
normal. I mean, kind of. blood work was normal. I took cultures and I removed the hardware. But the cultures were negative, so you were right. It was not infected. And then now what? We have a patient we suppose cultures negative, and I put him in a total cast, as Andres said. So the patient now has a total cast. Would you do a definitive treatment with that? It will be your first stage. Andres, what would you do regarding that? So, patient
Not
doesn't have
as
like
definitive
hardware right now?
treatment. I think it's a worker, but 60 years old is. I prefer to make a surgery in order to give the chance to return to her prior activity level. So I think in my hand I will do a surgery. For example, the use of a TTC in this patient could help in this objective.
Okay, and Pablo, what about you?
Yeah, so I think I agree that he needs a better solution for his ankle, but I would do nothing if his metabolic status is the same. So I try to make my patients and to make the compromise and get a better metabolic status, so they can tolerate and get a good recovery of the next surgery. The next surgery will be a big surgery, so it will fail probably if the diabetes is still with high parameters. So I try to get them to compromise and get normal or close to normal laboratory test before I make the definitive surgery.
Okay, so yeah, I agree with you. I do that. So we have to refer to internal medicine, and he got him stabilized as best as they could.
So Mario, sorry, you
So
have like
yeah,
a magic number for this one? We see where is your cut? Or like,
regarding
yeah, now
HbA1c, I
we
tried
will do surgery
less.
on you.
Yeah, less than 7. That's what I try to. That's my goal. Less than 7.
Okay.
And for every diabetic patient, I try to avoid surgery in diabetic patient that has a HbA1c over 7. Diego, what would be your surgery if you operate on this patient?
I agree with the TTC. I mean, you see the ankle is lost. The talus looks very awkward. Maybe a lot of osteonecrosis. Um, I don't see any other option.
With graft, with allograft, or not allograft? Or you will just shorten the leg?
I think I'll short him. I'm gonna be more. It will be more reliable. I mean, you could graft him, but then again, if the metabolic status is not as good, I wouldn't. I mean, allograft in an HC1 patient of 11. I'm afraid probably, and also that vascular status. I mean, probably shortening will. I mean, obviously, regarding mechanics, it wouldn't be the best option, but regarding the vascular option and the soft tissue condition wouldn't be that a bad idea. So probably I will shorten him a little.
Diego,
Okay.
in that
Mhm.
case, would you rather to do a talectomy and then fuse the tibia to the calcaneus, or you like
I may,
to keep some
I
of
may.
the talus?
I think when you see the CT scan, there's a part of the talus that may be salvaged, and I'll use that as a graft. But I don't know if I'm too comfortable. I mean, just putting a lot of allograft in that very, I mean, fragile patient.
Okay, so yeah, I did that. So I would do a TTC nail for this patient, and as Diego said, the risk of non-union in TTC are high, especially in diabetic patients. So if you remember this paper by Meyerson, is 50% of his cases didn't fuse, and all of those cases were diabetic. So it's important to keep that in mind if you're using allograft. And here is the last. Sorry. Here's the last X-ray. The patient healed. He's walking. He's happy. So I guess we got lucky with him. So that was the case. I would like to share with you guys.
Okay, and well, thank you, Mario. And we have
Mario?
only 5 minutes.
Diego,
Yeah.
can I ask Mario a
Okay.
question? When
Of
do you start weight bearing on this patient?
Long time, 3 months. But they usually wait very before, but I try to at least 2 months, and I try to do 3 months, and it depends of the images, but it takes a while for them to heal.
Yeah, so you take CT scans to try to
at 3 months mark,
identify
I
some
take a CT scan.
consolidation, and
Yeah,
then you allow them to weight bear?
At 3 months mark, I take a CT scan. If I see some signs of fusion, I allow him to weight bear. Yep.
Yeah, and all your TTCs you like to use like an extra TTC screw?
Yes.
Outside the
based on
name? Yeah.
Yes, I always do that. This paper dilution that gives you the same strength that a plate, so I take that extra screw, as you said.
Perfect.
We are almost there. We have only 4 minutes left, and I have a couple of cases. I think I'm going to be able to see just one, and it's going to be a straightforward case. No tricks, like Pablo said. Soccer player, 36-year-old. I mean, something went wrong. That's his ankle. When he checked to the ER, that's the reduction. I mean, the reduction of the tibia and the talus looks good, but the fibula looks awkward, doesn't it, Andres? We cannot hear you, Andres. Can you turn your audio on?
I agree with you. I think it's very similar than the case of Pablo. I think it is a Bosworth fracture. Yeah. So due to this condition, it's necessary to show us the CT scan.
Would you operate with him right away, or you think that reduction is? I mean, it's not that bad.
It's not that bad. It's not an emergency. You can wait, but if you have the OR right now, just do it. Yeah, it's not an emergency. You can.
I agree. Well, like you said, it's a Bosworth. I agree, and let me show what I did. So, well, I did. I repaired the deltoid. I put a hybrid construction for repair the syndesmosis. What do you think, Mario? Did I do a good job? Did I do a crazy thing where you do it differently?
I think we're on time though, but I think you did great. You get good reduction.
You have 2 minutes.
No, I think it looks okay to me. I don't know what you use on hybrid syndesmosis fixation in this patient. I would use just flexible fixation in this case, but the rest I think it's okay.
Pablo, what do you think?
Yeah,
1
can
minute.
you show me very quickly the CT?
Of course.
Yeah, so probably in this case, I would like to address the posterior mold, take out this fragment, and probably do the same as osteosynthesis than you did.
I got you.
I got to get the next guys going, but thank you guys so much. Awesome cases, Diego, as always. Thank you, everybody.
Thank you, Selene, for having us. We're looking forward for our next event in the future. And
It'll
thanks
happen.
our panel.
All right, take care, guys. For everybody attending, you want to click the link for the next session.